Hello, everyone. Good afternoon. I'm João Vitola from Curitiba, Brazil. It's my pleasure to be chairing this session with our colleague Paula Averbuch, and we'll get started.
Okay, I'm going to introduce Dr. Steve Unger, who is a nuclear cardiologist and clinical cardiologist and nuclear medicine physician, director of nuclear cardiology at the Queen Elizabeth Hospital and Lal McCune Hospital in South Australia. With his talk, read with the experts.
Thanks, Paula. Thank you very much for the organising committee for inviting me. It's late on a Monday afternoon. We've already had 4 days of conference, so hopefully this will be a bit light-hearted. So I want everyone to join in for this. It's an interactive session. So if you go to your apps, go back to the first page, to the interactive. Actually, go to this session and click on the top link, which will take you to the interactive session. So I'm just going to run through some cases that we've come through in real life. First patient is a 59-year-old obese woman with worsening exertional dyspnea, despite no change in her pulmonary function tests. She has a long history of chronic airways disease as well as hypertension, continues to smoke 20 cigarettes daily. Her treatment includes some antihypertensives and some puffers for her lungs. Her resting ECG shows left bundle branch block. The only other clinical examination finding of any note is scattered wheezes over her chest, although her forced expiratory time was normal. So let's get the ball rolling. I'll give you a few options how you would manage this patient. She's getting worsening exertional dyspnea. There's the anatomy test, coronary CT, some functional tests, stress echo, exercise, sestamibi, or would you do a vasodilator stress, sestamibi, or a dobutamine sestamibi? So I'll get everyone to vote. And they're coming through, and still moving. So there's a few people do, it's a real mix, isn't it? Probably the winner is dipritamol or adenosine sestamibi scans. A few people would exercise the patient as well, and there's a few coronary CT, so a good mix, that's what I expect. Because there's no right or wrong answer. We actually did an exercise sestamibi scan. So we put her on the treadmill, we provoked her exertional dyspnea within about 3 minutes on Bruce protocol. Obviously her ECG just showed left bundle branch block throughout. These are her stress and rest images, so I'll give you a moment to look at these. Interestingly, her gated images, which I think I've got on the next slide, showed, so it's not moving now. Good question. I think you can do either, although you can get left bundle branch block artefact in about 10 to 20% of cases. It's, in our experience, I still like to get the functional information as well, because I want to see what else is making her breathless. I'm still a big believer in the exercise stress test. I wanted to see indeed whether she got more and more wheezy during exercise, what her blood pressure control was. So you get a lot of other information from the exercise test. It looks
what
like
kind of heart rate increase you had?
We got her over 85%. So heart rate was around 130. Yeah. Okay, so this is some of her gated images. Her ejection fraction was only 24%. You can see this fairly global hypokinesis with a dilated left ventricle. Okay, let's have another poll. I'll give you some options. What do you think the diagnosis is based on her exercise sestamibi scan? You've got 6 options now. So is it some sort of artefact? Is there ischemia, an infarct, or multivessel ischemia? Or are we looking at a dilated cardiomyopathy? And most people have gone for the dilated non-ischemic cardiomyopathy, despite the large LA or anteroseptal defect, which is fairly fixed. Are you happy with your diagnosis so far? Are you happy that, okay, we've excluded any coronary disease, let's just treat it with anti-failure treatment? Or would you go further? So I'll give you the choices. Who's just going to jump to D based on your last answer and not do any more tests? Remember, this is not an elderly person, it's a middle-aged woman with risk factors for coronary disease. Well, despite your answer in the first one, there's only a few going for anti-failure therapy, 15%. A lot of people now want some anatomy as well. Okay. Instead of that, we did a cardiac MRI. This is her cine images, again showing that she's got a very dilated left ventricle with septal dyskinesis, obviously with the left bundle branch block, but global hypokinesis. And these are the delayed hyperenhancement short axis slices that I've just put into a cine motion picture for you. You can see there's no evidence of infarct whatsoever. Going back to the original Sesta-Mibi scan, the anteroseptal defect was completely fixed. There was no reversibility. So this patient we've treated as a dilated non-ischemic cardiomyopathy with a combination of breast and left bundle branch block artefact on a Sesta-Mibi scan. We've treated her with anti-failure therapy. So although a lot of people jump back to their looking for anatomy, I don't think you always need anatomy. You can get away with functional tests quite often, and especially if you've got access to cardiac MRI.
How do you exclude ischemic definitely on cardiac MRI?
You can do stress cardiac MRI, but we didn't do it in this case. We were happy that there was no infarct, that her defect was quite fixed, and that her hypokinesis was global. It confirmed the Sesta-Mibi findings, basically. You've got a face, Dr. Better.
What about one on hibernating myocardium?
There was no delayed hyperenhancement whatsoever. There's no sign of a subendocardial infarct. And that's the beauty of the MRI. With a good quality image like that one, we can be quite confident there's no scarring or fibrosis, so that we're not expecting hibernating myocardium.
We have, just for us to plan, how many cases you show?
Until I run out of time.
But so do we have time to continue the discussion of this case?
You can if you like.
Yeah,
I'm
so
pretty open.
we're open for discussions. Any questions or comments on this case? Yeah, Sharmila.
With that degree of LV dysfunction, it's probably not unreasonable to perform an angiogram. I think a lot of people would want to exclude epicardial disease one time and then move on.
I think, as we know from our specialties, there are different ways of treating patients. And as long as you come up with the right answer in the end, there are different ways of going about it. And as I saw, there was a wide spread of options. So it's interesting just to see what everyone else is doing. Let's move on to the second case, a 59-year-old man with known coronary disease. He had a previous LAD stent about 5 years ago. He suddenly blacked out with no warning, walking along the street. He went to the emergency room where his ECG was normal. He was admitted overnight, monitored overnight for 24 hours. Nothing showed up on his monitoring. Came down for an exercise Sesta-Mibi scan, ordered to exclude any silent ischemia, as he'd had no chest pain at all since his stent. He exercised quite well, 9 minutes on Bruce protocol, with a normal stress test. This is his Sesta-Mibi scan. The gated images were normal with an ejection fraction of 65%. So you've got the stress images at the top, rest images below, and some bullseye images to help you out as well.
You have a rest ECG?
Rest ECG was normal. Yep. Okay, well, don't tell everyone. I'll get you to vote. Don't give away the answers. All right, everyone can vote. Now, there might be a bit of bias here. So has he got inferior ischemia? Has he got an inferior infarct? Has he got multivessel ischemia, or has he got some sort of artefact? And most people agree that there's inferior ischemia. That seems to be the top answer. Well, I had another look at his images. Hang on, before I go to that. And I just wasn't happy with the shape of the left ventricle. If you look down towards the apex on the stress images, the left ventricle looks a bit distorted. And although there is definitely an inferior defect, I think there's also a bit of a defect across 180 degrees away
Yeah.
from it as well.
Anterolateral.
Yeah. So what I did is had a better look at the cine gated images, and there's a lot of motion artifact in this patient on the stress scan. So we motion corrected it on the right. Although it's not ideal, almost that defect almost completely resolved, and now his bullseye's back to normal. So I was quite happy with this guy. He's exercised 9 minutes, a negative stress test. There's no ischemia going on.
Using CT to motion correction?
We do. I haven't shown it here for the purposes of this case. It might have helped. But I think it's just the shape of the left ventricle and those diametrically opposed defects that can give that away. Makes you look harder and go back look at the cine images. So it's very rare in our department. Usually the techs pick up motion and restart the scan if necessary. But you can go back and correct some of it, particularly in the y-axis. All right. Third case, 68-year-old man with quite a large abdominal aortic aneurysm, being worked up for surgery for this. He has no history of coronary disease or chest pain. He's an ex-smoker of 60-pack years with other risk factors of high blood pressure and high cholesterol. He's on an ACE inhibitor statin and puffers for his lungs. And he can't walk his dog very far. The only exercise he does is walk his little dog down the street, but he can't even make it 100 metres without stopping at a slow speed. His resting ECG is normal. So what are we going to tell the vascular surgeons?
There's no chest pain?
No chest pain. No history of chest pain. So here's a man who's got arterial disease. How are we going to manage him? So I'll give you time to think about this. Should we just go ahead and operate on his AAA? He needs it done. There's a clinical need for it. Should we only proceed with perioperative beta blockade? Should we do a pre-op exercise sestamibi scan, a pre-op diapridamole sestamibi scan, or a pre-op coronary CT? Let's see. Moderately bad. Yeah, he gets breathless and wheezy pretty easily.
Is he on a beta blocker?
No, he's not on a beta blocker. So it looks like most people would give diapridamole, which even in a man that's got some chronic airways disease, it depends how reversible it is. But I find with people with COPD, quite often I'll give them some Ventolin with a spacer before I give the diapridamole. In fact, before I give any sort of stress test in these patients with COPD, I give them Ventolin. It gets them further on the treadmill and it prevents wheezing during diapridamole. I find we can, unless somebody's got very brittle asthma, you can get away with diapridamole in almost all patients.
Why don't you use it as a shorter acting?
Either or, yes. In our department we use diapridamole, and we've got aminophylline on hand. And we always reverse it with aminophylline. So, no.
Can you
Not in
comment a little bit more about this methodology that you use of pre-treating the patient? Because if you use guidelines, I mean, this would be a contraindication for diapridamole, right?
A relative contraindication. Severe asthma is a contraindication. This man has COPD. He's got chronic lung disease,
Okay.
which accounts for like 50% of our patients that come to our department. But I've never run into a problem with any of them as long as I pre-treat them with some Ventolin first. And sometimes their technique is terrible, so we always use a spacer. And
Okay.
a couple of minutes later, we start the test, and we
If they
don't
walk
have any
into the
problems.
room, you listen to their lungs,
Yes.
and they are wheezing, would you still do it?
Then I'd give them the Ventolin and see if I can get rid of that wheeze. And I've got my aminophylline handy.
Yeah.
Yeah.
Okay.
So yes, we sometimes do provoke a little bit of breathlessness, but it always reverses just with another puff of Ventolin and then the aminophylline afterwards. So I
Next.
think it's quite safe, and certainly based on the answers in this room, 70% will do the same.
You've not given this dobutamine as an option here.
I did, didn't I? No, I didn't. Okay, because I didn't give dobutamine.
Now, what about going? You know, this man needs an operation.
His artery is going to be full of calcium. He's a 65-year-old heavy smoker. 68-year-old.
Certainly it's a class 1 recommendation for that. It's major surgery.
In a 68-year-old man,
Perfectly
arteriopath,
a CT in that person.
what are you going to find, Barry? 99.9% chance he's got diffuse
All you've said
coronary atherosclerosis.
may or may not have a
which is what I think that's what's important for the purposes of this patient's management. I, well, Barry, I think this guy's got a really high pre-test probability. He's got a AAA, he's been smoking for 60-pack years. He's going to have calcium everywhere through his arteries. And then what are you going to do with him? Are you going to send him for a bypass in somebody who's asymptomatic? Well, that's what I'm coming to. What I thought we should do, Barry, is look at the guidelines. So the latest guidelines came out in 2014 from the American College of Cardiology and Heart Association. They've changed a little since the previous ones from 2006. Whoops, sorry, wrong button. Essentially, it's not emergency surgery, so we keep going down here. He's got an elevated risk, you would think, based on his risk factors alone. And then you go to their functional capacity. Now, as I said, this guy's functional capacity is fairly poor. Yeah. So it's no point doing... If he was very good functional capacity, you'd go straight to surgery. Moderate to good, you'd probably still go to surgery. But this guy, we don't know if he's getting ischemia because he can't walk more than about 1 minute down the road before he has to stop with his airways, with his COPD. So in these patients, pharmacologic stress agent has a class 2A indication. And if it's very abnormal, then you might go to coronary revascularisation. So that's what I'm getting at. I don't think coronary CT, I think he would have definitely had diffuse coronary disease. But I want to know how much ischemia there is and whether he needs coronary angiography and bypass before they repair his AAA. Anyway, this is his results. So diprotamol stress scan on the top rows with the corresponding rest images directly below and the bullseye down at the bottom. Now, his gated SPECT images actually showed a normal sized left ventricle with normal regional wall motion and an ejection fraction of 63%. So no evidence of infarcts on his gated images. So if everyone's had a long enough look at his perfusion images, what do you think? What would you do with him now? Who still wants to go straight to AAA repair? Who would like to put him on beta blockers? Who wants to do... Barry's got C in mind already. He's already done his. Or who wants to do a coronary angiogram? Coronary angiography, and I think that's reasonable. He's got multi-vessel ischemia in his circumflex and LAD territories. So these are the sort of patients we want to discover before they go to major vascular surgery. His cardiovascular morbidity would be very high during his operation. Put him on beta blockers, well, we know that he's wheezy and everything. I don't think that's enough. I think this man is the man that needs to go to coronary angiography and almost certainly bypass surgery. So we got there in the end, Barry.
So he got the bypass before the...
Yeah,
repair?
He went on to have bypass. Now, the other way of looking at this is what's going to be his long-term prognosis, whether he's having his AAA repair or not. We know that in patients with moderately or severely abnormal, and this guy's got at least two vessel ischemia, he's going to do better with revascularisation in the long run. So regardless of whether he's having his operation or not, I think that's another way of picking whether it's worth doing a preoperative test, not only for the surgery, but for his long-term prognosis and management.
He didn't have transischemic dilatation?
No, not obviously, but we don't always see that.
Oh.
Particularly with diprotamol, it's less likely. Although you can see it, it's less likely.
He has normal LV function, right?
Yeah,
normal LV function.
normal LV function.
Let's consider this was not a pre-op evaluation, okay?
Yep.
Would this be an ischemia patient? Would this patient be a candidate?
Is it too much ischemia? Is there a cutoff? I know you need at least 10%.
No. If he has left main, that would be an exclusion criteria. Yep. He has a normal LV function.
From memory, he didn't have left main.
No left main?
No, he had quite severe LAD circumflex and some right coronary artery disease, so triple vessel disease, which went to
I think he would be a
bypass.
candidate for to be randomized for the ischemia trial.
Yeah. Yeah. All right, I've got time for, I think, one more quick one. Is that right? Have I got time for one more?
Just before proceeding, I would like to know that if we have the optional vitamin, was that right to use the vitamin in these patients with a 6 centimeter aneurysm?
I don't know if the literature in that. I don't think there is any cases of adverse effects with dobutamine in aneurysms. I've never heard of that.
Actually, when we have aneurysm, it is contraindicated to use exercise or to increase the heart rate.
A relative contraindication.
Yes, they
Yeah.
may be rupture of the aneurysm. So
Yeah.
even in
There is a
moderate-
theoretical risk with dobutamine.
Even in
Yeah.
the moderate asthma, it is much easier to use a spray of salbutamol and then perform dipridamol than.
Yeah. Well, that's what we thought. I always find that safer.
Has anybody published on this? Pre-treating patients with salbutamol and then
Yes.
giving?
Yes,
Is this
I
being
have seen
published?
an article in moderate asthma, which is published, I think, in the Journal of Nuclear Cardiology just a few years ago, and they found that there is no significant complication in these patients, and they can easily use dipridamol in patients with moderate asthma.
I think it's one of the most important drugs to have in your stress test room is Ventolin. We use it all the time. Anyone with any hint of wheezing, we'll give them some Ventolin and then get on with the stress test, whether it's exercise or dipridamol.
Helps with their heart rate too.
Only if you over-treat them.
I think, Steve, it's one of the big problems with Australia and a lot of other places around the world that we just don't have regadenoson. Because
Yes,
I'm sure
exactly.
If I'd say you give regadenoson for this patient, it's a no-brainer.
We would love to have
Yeah, of course.
regadenoson, of course. I'll just run through the last case very quickly because it's an interesting one that we don't see very often. 56-year-old woman, ex-smoker but no other risk factors. She developed sudden onset severe central chest heaviness and shortness of breath while visiting her husband, who was a hospital inpatient. Did not respond to angina, went down to the emergency department. Was found to have a mild tachycardia, blood pressure 105/70, otherwise normal examination, normal chest x-ray, normal troponins. This was her ECG on arrival. And just to cut the case short, there's some hyperacute T waves anteriorly, but nothing diagnostic of an anterior MI, nothing to send her to the cath lab. So rather than wait for a second troponin or send her to the cath lab, we did an acute chest pain MIBI scan. And this is an older case, so the images aren't that great. I've just got a few pictures there. So this is just her acute chest pain scan. I don't have any rest scan. This is injected while she still had 8 out of 10 chest pain. And the bullseye below. She went to the cath lab based on that acute SESTA-MIBI scan. As you can imagine, it's very abnormal. She had normal left coronary artery, normal right coronary artery. This is her LV gram. And this is something that we do, yes, it's already been called out. This is a case that we recognise more and more in the last few years. There's more and more literature on it. And up to 5% of postmenopausal females who present with acute coronary syndromes turn out to have Takotsubo cardiomyopathy, which is E other. Her ECG's evolved just like an acute anterior infarct. On 24 hours later, we did a repeat resting scan when she was pain-free just to show there was some reversibility. It's starting to improve. MRI showed poor function, which improved over a couple of weeks. And so she's got what's called Takotsubo cardiomyopathy or broken heart syndrome. First reported by the Japanese back in the 1990s, and it hit the English literature in around 2000, 2001. If we go back to this case, you might see up the top, this was 1999. So we had no idea what this was when I did this. I was a registrar. That's why the images aren't that great. But it was a very interesting case at the time. And we don't see it very often in nuclear medicine because they go straight to the cath lab because they're thought to have acute coronary syndromes. Rarely, only during working hours. And when they've got one of those equivocal ECGs, which is all she had. She had an equivocal ECG and they didn't want to wait for a second troponin. So I think there's still a little role to play for acute hot MIBIs too. And you might find this Takotsubo occasionally.
What would you expect your resting views to look like in 3 years' time?
in fact, in 6 weeks after this, was completely normal. Completely normal. She made a full recovery with no... there's about a 5 to 6% recurrence rate in Takotsubo. Yeah, it's not huge, but up to 10% patients go into fulminant cardiac failure and shock. Yes, it's possible. Yes.
If you've done gated image, do you think we could make the diagnosis based on the sitting gated image?
Yes, it would have helped, definitely. And we've had a couple of cases since where we thought possible Takotsubo, but they've all turned out to be severe proximal LAD disease. So this is the only definite one we've got in our lab. All right, thanks very much.
Thank you so much, Steve.
Yeah.
So we'll call Dr. Nakajima, who comes from Kanazawa University from Japan. He'll talk to us about heart failure and MIBG and some interesting cases about that.
Thank you very much for your introduction. In this talk, I'm going to talk on MIBG, but the problem of MIBG is not so much used in the world. So the first question is, how many doctors have access to MIBG, or do you use MIBG? Well, okay. But still, there are not so many doctors, so you will be our expert in 20 minutes. Okay. So the running objective of this is probably I need to explain some basic ideas why MIBG is somewhat difficult, and we also think that the idea of risk stratification is very important for MIBG imaging. So I'm going to explain about it with some questions. The first question is very simple: normal, which is normal, or which is abnormal? Probably it's not necessary to ask you. If you take a regional interest here to calculate heart to mediastinum ratio, the left side is high, and this will be low. So I can stop, I can finish my talk today. Okay. But anyway, well, it doesn't work. Sorry. We have summarized how to standardize the H2M ratio, Dr. Stronka in the Cedars-Sinai Medical Center commented on the editorial. The measurement of H2M planar ratio from MIBG is deceivingly simple, but it may not be that simple after all. So I'm going to explain why this statement occurred. So there are actually so many MIBG images depending on the hospitals. For example, here, this will be good and this will be bad, but actually so many borderline cases. So it's sometimes problematic. Now, there are 26 million heart failure patients worldwide, and 6 million in the United States, and more than 1 million in Japan, and usually high rate of hospitalization, readmission, outpatient visit, and high rate of comorbidities. Therefore, it's a big burden to healthcare system. Particularly in Japan, it's in aging society. You see the number of population is rapidly decreasing in Japan, and aged population more than 65 years will be 41% in 2055. And when we see a population pyramid, it's not a pyramid. The shape is quite different. Now, when we see MIBG development, it started in Japan in 1992 as a clinical use, and some preliminary observations continues, and the standardization was going on, and Japanese Circulation Society guidelines approved the use of MIBG in 2012. On the other hand, in the USA or European countries, For example, FDA approved MIBG in 2013, and now Admire ICD studies are going on. But anyway, international multi-center trials will be necessary to obtain more approval. So, as you know, MIBG is an analog of noradrenaline or norepinephrine and shares storage and release in the sympathetic nerve terminal. And uptake one mechanism is a mechanism of accumulation. So in 1989, it's in Kanazawa University's image. You can see in the patient A, this is a patient with AMI after PCI, and you can see a significant perfusion, a slight perfusion decrease in the thallium-201, and MIBG clearly shows denervation. Although we saw Takotsubo syndrome in the presentation just now, Takotsubo syndrome shows a clear denervation localized in the apex. It's very characteristic. And patient B is hypertrophic cardiomyopathy. A slight hypertrophy is seen in the septal wall, but you can also see some decreased activity in the septal wall by MIBG early image, but you can see again a rapid washout from the septum. So this sort of abnormality is sometimes seen even in hypertrophic cardiomyopathy, and it has some relationship to the prognosis. And quality of conventional MIBG images are unfortunately not so good because the uptake is less than 1%, images are blurred, and liver uptake is always a problem. But this is a standard image. But now, since we can use D-SPECT, the image quality has become much, much better like this. But still, the left ventricular count is from 0.5 to 2.4 million counts per study, quite dependent on the patient condition or patient heart failure condition. But anyway, Japanese Circulation Society guidelines approved the use of MIBG as a class 1 indication for assessment of severity and prognosis of heart failure, 1, and 2A for assessment of treatment effect of heart failure. Some variations still exist. As for the region of interest setting, it's a little bit problematic, but in Japan, we decided to use a semi-automatic method, just putting the center of the heart and the other, thereafter it goes automatically. So the first question is, there are two patients, patient A and patient B. So which do you think is higher cardiac uptake? When you calculate H-to-M ratio, H-to-M ratio is higher in patient A or B or equal. What do you think? If you think patient A has higher H-to-M ratio, could you raise your hand?
A.
Okay.
Higher? A higher.
And patient B, okay, it's equal. Okay, thank you. So this sort of question is sometimes very confusing, even for well-trained cardiologists. So what happened? This is the same patient. The left side is obtained by a low medium energy collimator, and the right side is low energy high resolution collimator. It's very common in the United States, but left side low medium energy is very common in Japan. But anyway, you can note that the penetration, septal penetration is quite different. On the left side is 0.24%. On the right side, it's nearly 5%. It creates a very different image quality, and the H-to-M ratio will be, of course, lower on the right side. So we performed the calibration phantom experiment, and as you can see on the right side, low energy high resolution, low energy medium energy low penetration collimator shows quite different image, And more than 1,000 experiments are performed in Japan and more than 200 experiments in Europe. And based on it, we made a conversion coefficient depending on the camera collimator system. The calculation is relatively simple. Adjusted HMR can be calculated by the measured HMR using conversion coefficient of the institution. And we try to change all H2M ratio into medium energy general purpose condition. As you know, the Admire HF study is said 1.6 will be a good indicator for bad and good prognosis, and many studies use threshold as an important threshold. However, there are still some variations. For example, in Admire heart failure studies 1.6, but here the next one in Japanese pooled database is 1.68. And in a European multi-center study, it's 1.75. There's still some difference. But there are so many patients between 1.6 and 1.8. So if we compare the H2M ratio, threshold of H2M ratio to conversion coefficient, it will be like this. For Admire H2M ratio, it will be 1.6. But for the Japanese studies, it will be around 1.7. But if you use medium energy collimator, it will be around 2.0, although they are the same, actually same. So the left side, this was obtained in the Hamburg University, and the calculation was 1.44, so less than 1.6, a bad prognosis. But on the right side, its LME collimator in our university is 1.64, is good prognosis. But in fact, when it's standardized, it's almost the same. So this is the answer. Next patient is, there are two patients here. The left side is a 54-year-old man with DCM, NYHA class 3, ejection fraction 90%. And on the right side, this is a patient, 33-year-old woman with DCM, NYHA class 2, and ejection fraction similarly around 20%. So considering the story of my talk, it's not so difficult question, but do you think patient A is at high risk or patient B is at high risk, or it's similar? So if you think patient A is at high risk, could you raise your hand? Okay, and patient B, no one, and equal. Okay, thank you. So we try to calculate the death rate based on these images. Although patient A and patient might be different, but how far is it different? It's a problem. So we obtained images from 1,300 patients. The follow-up time is 15 years. And then in the ischemic etiology, patient with ischemia, pump failure, sudden cardiac death will be in the 50%, but in non-ischemic etiology, pump failure death will be in 70%. This is background of the patients. And we could make a risk model to calculate exact mortality rate for 2 years, relatively short term, and 5 years for relatively long term. Then we could make a risk model or a risk chart. So if you know NYHA class and the ejection fraction, male or female, and age, the total mortality rate, estimated mortality rate will be something like this. For example, in the right lower graph, the estimated rate will be from 10% to 70%. It's quite different. So we combined collimator choice and risk model. And then, for example, it's a patient has severely reduced H2M ratio and NYHA class 3 and the age more than 65. the mortality will be 37% per 2 years, but here it's only 1%. So wide range of mortality can be estimated. It's partly preference, but you can understand if you consider the weather forecast. It can be said as a dichotomy, today it's fair, today it's sunny or rainy. But you are probably accustomed to use the today chance of rain will be 70%, then you are going to take an umbrella. So similarly, prognosis can be said like that. Simply saying it's more than 1.6 or 1.7, more or less, it's good or bad. But in fact, chance of rain.
2 minutes, okay?
Okay. Chance of rain will be 70%. A chance of death will be 70%. It will be also a good expression to explain about the patient risk to the cardiologist. So the patient H2M ratio is 1.6. But as you can see here, if the patient has NYHA class 2, age 50, and LV ejection fractions 60%, mortality will be 8%. And then NYHA class 3, age 75, ejection fraction 30%, it will be 47%. So quite a big difference. Now, the first patient's death rate will be 44%. And the second patient, only 4%, 10 times different risks. So we can calculate the risk like this. And actually, in the first patient, this patient has CRTD device implanted and experienced a BT episode. And this is true, and the risk model can be actually work in any ranges of ejection fraction and also in any ranges of BNP. And when we calculate the mortality rate, for example, we say the risk will be 5%, it's actually 5%. When you say it's 10%, it's actually 10%. Except for the very high risk patient, we can estimate the mortality rate. So, and also 2-year risk model is much better compared with other variables alone. So it's very convenient. I'm going to briefly talk about the SPECT. SPECT normal databases are made in Japan. For example, in this case, you can see some decreased activity in the inferior wall on the left side map. But if you use correctly the normal database, the abnormality is only in the apex. This sort of calculation is very important to apply MIBG for daily clinical practice. Okay. So sometimes it's difficult to take a region of interest. And arrhythmic event might be estimated when the H2M ratio is defect is intermediate. And also you can see appropriate ICD therapy is usually seen in mid portion of the H2M ratio. This is also very interesting phenomenon. So my proposal is let's use the same standard H2M ratio, but before that, let's use MIBG for clinical practice, particularly in the United States. Okay. And another one point, this is Lewy body disease. And in Japan, actually, 60% of the application is for Lewy body disease. That is also very important. Price, MIBG is $410 US dollars. And even if we include SPECT, less than 600 US dollars. So if the price will be lower, you can probably very effectively use MIBG. Thank you.
Thank you. One question. Do you stop beta blockers before doing the MIBG?
No. Usually, there are no specific restriction for beta blockers. For example, the antidepressant drugs will be stopped, but otherwise, we usually do not stop it.
But what's the effect of the beta blocker on MIBG uptake?
Yeah, so strictly speaking, there are so many possible drugs which may affect the uptake of MIBG, but as for the clinical practice, we did not say like that.
Thank you for your excellent talk. I just wanted to know that you are using the lung heart ratio in two-dimensional images of a planar image. Don't you think that if we move to the three-dimensional aspect slices, it would be much better? Because defining the region of interest over the heart is not very easy. Sometimes overlap with the lower pole of the lung. And
Yes, I understand what you mean. But actually, when there's a very large defect in the inferior wall, it's very difficult to determine the border of the heart. So although we also try to calculate H2M ratio based on aspect, so diagnostic ability was not so much enhanced. Similarly, the Emory cardiac toolbox, Emory's data showed even in ADMIRE heart failure study, SPECT study was not so good, better than the planar image. But
Okay, just less question because of time.
A very quick question, Ken.
Yeah.
In the same as which Joao asked about beta blockers, what about amiodarone with the iodine? Do you find any effect there?
Yeah, so I cannot exactly say so each drug's effect. Strictly speaking, we need to compare the patient in both situations. But actually, there are not so many studies like that, only for animal models and so on. No. But comparing the results of the ADMIRE HF study, patients who had some medications have different H2M ratio threshold. It means probably slight effect will be observed if carefully controlled studies are done. But for clinical practice, it's not easy to stop everything, so we usually say nothing about it.
Okay. Thank you so much. Huh?
Thank you.
So we'll ask Dr. Shamila Dorbala from the Brigham in Boston to present about PET.
Thank you, Joel. Good afternoon, everyone. So I actually do not have questions embedded in my cases. Basically, I want to focus more on image interpretation and try to do as many cases as possible. So here's the first case. So what you're seeing here is the stress and rest images in alternate rows. And here's your polar plots and the computer-derived scoring. All right, so interpretation of cardiac PET, this is N13 ammonia PET. It's very similar to SPECT imaging. The image display is the same. And by default, all the images are attenuation corrected. In this case, it's CT-based attenuation correction. Here's the gated file. The gated file, also you see two sets of images, the stress on top, rest on the bottom. This is somewhat different from SPECT in that the gating here is during maximal hyperemic stress, as opposed to SPECT where you wait 45 minutes or so and it's post-exercise or post-vasodilator, whereas this is peak hyperemic stress. So you can look at changes in EF from rest to stress. Then the quality control tool that you use for SPECT obviously is the rotating projection. Here we use two different quality control tools. One is this, which is the PET and the CT. We look at the overlay and we try to see if this overlay is accurate. And the other quality control tool is to look at the coronary flow reserve. I don't know how this will play now. All right, so you can play the dynamic images in a cine loop format, okay? So if you play this, you can see if the patient has moved during the PET scan. So there is no rotating projection images with PET because it's a circular gantry and all the crystals are looking at the heart simultaneously. So you don't have the standard equivalent of rotating projection. But when you compute your dynamic images, you can display them in this format. Sorry, okay. You can look at it in this format and then you can see the cine moving images, all right? So what's the problem here, right? What's the reason for this anterolateral defect? See this area? So the question is this ischemia in the diagonal territory? Is the registration accurate? Not accurate, exactly, okay? So this is a problem, particularly with CT-based attenuation correction, because the CT is obtained in like 10 seconds or so, and the PET image with ammonia is 20 minutes. Sometimes you see that they don't match up, and here you can see that the emission image is overlying the lung field, which has a low attenuation coefficient. So when you correct for it, there's under correction, and therefore you can actually see perfusion defects. So in a case like this, where there is misregistration but no physical motion on this, then you worry that the abnormality is actually an artifact from misregistration. So how do you deal with this? You go ahead and re-register the images, the CT and the PET. This has to be done on the acquisition console. This is not on your reading station. So you have to re-register it, develop a new attenuation map, then correct the images with the new attenuation map, and then you can get the new reconstructed images, and here you can see that there's no abnormality. So the most common area of misregistration is the anterolateral wall, where your CT overlies the lung field. However, if the CT moves, if the emission image moves this way into the right heart, we typically do not see any problem. The reason is the attenuation correction is only affected by three main parameters. One is calcium or bone, the second is air, and the third is soft tissue. So if you have a movement within the soft tissue, typically that doesn't impact it. But if there's movement from soft tissue to air, you will see undercorrection. And if it is from soft tissue to bone, you may see overcorrection. And overcorrection becomes more of an issue, particularly with hotspot imaging like sarcoidosis, where you're trying to look at focal uptake, but otherwise it's not a problem. So final impression, misregistration artifact, which is corrected. So here's another. This is a rubidium 82 image. Here are your images and PET-CT fusion. So what do you think is happening here? Why is there an anterolateral defect in this patient? And here's the registration. Patient motion. Right, so this looks like patient motion. Again, the shape of the heart is distorted. And where is patient motion? Is it on the emission or on the transmission image? It matters, because if it's a misregistration between emission and transmission, you could use software and correct it. But if there's physical patient motion, either during the transmission or the emission, then it's a little harder to fix. So in this case, we believe it is actually patient motion during the CT scan. And that makes it much harder to correct, because you don't have any transmission map to correct, and this becomes much more challenging. So what's our option? We can look at non-attenuation corrected images, and here's the non-AC. So the non-AC images typically with PET are problematic, because the deeper structures of the heart, such as the septum and the inferior wall, are more attenuated than with even SPECT. Because even if one of the two photons is attenuated, the scanner will ignore the other, because it will not recognize the coincidence detection. So therefore, ASNIC actually recommends not to read the non-attenuation corrected images. If there is physical motion during the transmission scan, you'll have to repeat this study. So misregistration due to breathing can be corrected. And this is not infrequent. Almost 40% of the scans may show misregistration with hybrid devices with CT. The way you evaluate is look at the overlay. Software is available to correct. Remember, do not interpret the non-AC images, and motion during the transmission scan cannot be corrected. Typically, it requires a repeat study. So next case here, 59-year-old with hypertension and hypertrophic cardiomyopathy. Patient had an MRI that was normal. Patient presents with typical chest pain, dyspnea, palpitations. She's taking multiple medications, underwent rest and regadenoson stress N13 ammonia. We use somewhere between 20 to 25 millicuries of ammonia. It's a 20-minute scan acquisition, and standard dose of regadenoson 0.4 milligrams. Now here's your stress and rest image. Okay. And the question is, what's the reason for the anterolateral defect here? Here's the registration, and here's the dynamic images. So what do you think about registration here? Registration looks okay. And what do you think about the dynamic images here? Patient motion, right? So you can see the heart starting off at the bottom, and then with time you can see the uptake moving up. So this is how physical patient motion would be detected on the dynamic cine loop images of the dynamic patients. The other thing we need to remember for hybrid devices is to look at calcium score and ancillary findings. This patient had no calcium score, and this coronary flow reserve, you can see here, in each territory it was 2.0, 2.3, 2.4, and overall it was 2.14. So CFR was normal both regionally and globally. So here's the image which is distorted by motion. You can see the shape is odd and there's a lot of noise here. The rest image is very sharp and clean. And the motion correction is available with PET. So when you look at the dynamic multi-frame images, you can correct for patient motion. If you correct that, you can see it's a much sharper image and looks nearly normal here. The other option with for motion correction is you can remove the frames with motion. So when you have 37 frames of images, if the patient moved on frame 30 to 35, you just remove those and resum the other images. So final impression on this case, normal variant, motion correction corrected by motion. So here you can see there's a little bit of a lateral wall defect, and that is something that you would see with N13 ammonia. So we think that's what that is. So patient motion during PET is difficult to detect. We need to pay careful attention. The technologist has to be watching the patient. If you see it, you can delete the frames and resum. You can correct for the motion on the dynamic image frames. Here's the next case.
Will the motion affect the CFR levels as well too?
It does. In fact, this is something that I was discussing the other day. So CFR is really great, but if you think about it, CFR is not, first of all, with motion correction, what happens is your input function will change. So you will have blood pool activity spilling into the myocardium and the other way around. So your CFR is going to be completely incorrect. However, the commercial software now allows for motion correction before you do your CFR. But if you want to go one step further, think about it. CFR, the dynamic images are not corrected for breathing motion. They're not corrected for cardiac motion. They're non-gated images, the dynamic. So it's kind of a mishmash of blurring from breathing, cardiac motion, embedded in there. All you're correcting for is physical patient motion. But still, this is the best tool that we have at this point. All right. So that's a great question. All right. So next case, patient had cardiac transplant 11 years prior to this test because of giant cell myocarditis. Hypertension, taking multiple medications, no chest pain or ECG changes. And here's the stress and rest. See a lateral wall defect there. This is something that we see very commonly with prior cardiac transplant patients or cardiac surgery. You almost see a double shadow here in the lateral wall. This is because if you look at the gated, here's your registration, which is good, and here's your CFR. There's no motion, and overall coronary flow reserve is 3.0. So the patient has preserved coronary flow reserve and no misregistration. And here's the gated image. Oh, somehow it's not looping. So do you see the problem with the gated image? There's paradoxical septal motion, and that's nicely seen on the polar plots here. You can see that the septum is not moving, whereas the lateral wall is hyperdynamic. So the reason for this double shadow in the transplant patients is because of actual physical motion of the lateral wall being hyperdynamic compared to the septum, and that causes volume averaging. So sometimes what we do in these cases is we try to read the end diastolic images, and that gets better on the end diastolic. Sorry.
You see similar thing with LVDB?
We see this, but it's much more obvious with the transplant or post-op than with left bundle. But yes, we can see this with left bundle as well. Yeah. And again, you see this lateral wall defect. This is the normal variant with N30 pneumonia. The other normal variant you see with N30 pneumonia is sometimes increased lung uptake. This can be seen in smokers or in patients with low ejection fraction. With rubidium 82, you do not see increased lung uptake with low EF. In fact, you see the inverse. You see increased blood pool activity with rubidium 82. And that makes the image much more fuzzy. With ammonia, it's a lot more lung uptake. And this is the usual situation where it's more lung uptake at rest than at stress. And we believe that's because during stress, because of myocardial hyperemia, you're seeing a lot more counts in the myocardium. So the lung looks apparently better compared to rest. So this is increased lung uptake, something to keep in mind. So here's an 82-year-old woman with known coronary disease, prior stenting to the circumflex, multiple coronary risk factors. Here she has a left bundle, underwent rest and vasodilator with N30 pneumonia, and here are the images, stress and rest. So the question is going to be lateral wall again, all right? And here's the polar plots showing that lateral wall defect. Here's the gated study. Here's your registration. And here's your coronary flow reserve. All right. So no motion. Registration is good. And the scan shows ischemia in the infralateral wall, right? So the patient did have a prior stent, so there was increased calcification, but it's because of the stenting, I think. And if you look at the CFR, numbers are not showing up. Overall coronary flow reserve was 1.1. Regionally, it was 1.1, 1.2, and 1.2. So this patient had significant coronary microvascular dysfunction in all vascular territories. And you saw that she had multiple coronary risk factors, known atherosclerosis in the past. And here's a situation where the concern is ischemia in one territory, but global microvascular dysfunction / multivessel disease. So that's going to be the question in this case. Here's the calcium. You can see a lot of calcification. She did have a stent in the circumflex. There's LED and aortic calcium. So there's moderate ischemia, high calcium, globally reduced CFR. So once you've made sure the quality of the image is good, there's no motion, no artifacts, then you can read those ischemia. But remember to always take a look at the coronary flow reserve and make an interpretation based on the combination of perfusion defects, flow reserve, and ejection fraction. And here her ejection fraction actually was 72 at rest and 61 at stress. So everything was pointing towards high risk. On angiography, she had an occluded RCA, 80% LED. Diagonal one was 99% stenosed, which was stented, and circumflex had 60% disease. Here's the next patient. I think I have 2 more minutes. One case, 75-year-old with known coronary disease and prior CABG, presenting with typical chest pain and dyspnea, has multiple risk factors, a lot of different medications. Here's the stress and rest pictures, polar plots. All right. So you can see all of this ischemia in the inferior wall. Gated study shows paradoxical septal motion. She did have prior CABG. But otherwise, overall normal ejection fraction, low normal. And here's your registration. Looks decent. And here's the coronary flow reserve showing no patient motion. So basically, we correct for patient motion before we create the CFR file. So you won't see it because we've already adjusted for it. And if you look at the coronary flow reserve here, globally it's 2.25, LAD is 2.2, circumflex is 2.6, and RCA is 1.9. So it's consistent with the inferior wall ischemia. The right coronary distribution has the lowest, but then it has normal CFR in the other two territories. So here's the CT scan showing extensive coronary calcification, impression single vessel ischemia in the right coronary artery, normal CFR in the other two territories. So although the patient had prior CABG, CFR is reasonably preserved, suggesting that this is a low-risk scan. Patient does have extensive coronary artery calcification, as is usually seen in patients with prior CABG. So I think we can stop there.
Thank you so much,
Thank
Dr.
you.
Rabala.